My name is Julia White. It's a pleasure to talk about NRG-BR007 of the DEBRA Trial, which stands for the de-escalation of breast radiation in early stage 1 hormone-sensitive breast cancer. The goal of this trial is for us to actually optimize or really tailor the right radiation treatment post-lumpectomy to the right patient. We know that radiation reduces the risk of in-breast recurrence, but we also know that there are some patients after lumpectomy who will never have a recurrence. And we want to make sure that we're not over-radiating patients who otherwise would do well without the radiation. There's been numerous randomized trials looking at just the tumor size or the patient age to find who can omit radiation safely without a significant excess number of recurrences in the breast. And they've been pretty much unsuccessful in identifying consistently a population that can omit the radiation. And so we're really excited about this trial and this topic because we think that biology is the key here in using the oncotype recurrence score, which in past NSABP studies has been prognostic for local regional recurrence as well. So we are asking the question in patients with a low recurrence score, 18 or less in this case, could these patients omit radiation? This is a non-inferiority design, and we're saying that at 10 years, we anticipate there'll be less than a 4% difference, absolute difference in local regional recurrence, and many women might not want to go through the radiation for that, and so this is what this trial is testing. Well, I think particularly for the international sites, we know that radiation is not accessible or maybe, available immediately to patients internationally. So it could be that this can help women elect to choose to keep their breasts and not have to go through the burden of radiation. Now, even though radiation has become fewer and fewer treatments to the breast after lumpectomy, it nevertheless still has some toxicity, just have side effects. If it's not really clinically meaningfully adding to local control, why should you go through it? So I think there's an opportunity here to address overtreatment across the world, maybe make breast conservation more doable for patients, and also reduce healthcare costs. Obviously, if you're not radiating, you're eliminating that cost to the healthcare systems. So when we look at the United States and we say, okay, there's about 200,000 new invasive breast cancers per year, maybe roughly 50% of them are stage 1, and most of them will get radiation. We expect that maybe in the U.S. alone, that up to 20,000, 25,000 women could omit radiation in this classification of stage 1, hormone sensitive, between ages 50 and 70, and with a low recurrence score. So we think that's a pretty meaningful number just in one country, and you can imagine how much larger that would be worldwide. I think the most common questions I'm asked by sites is who is eligible based on either very small or very large tumors or histologies. And we try to make this as wide open as possible. So the T1A tumors less than 5 millimeters, at least here in the US, are not part of the NCCN guidelines to have an oncotype recurrence score. So we do have a screening pre-enrollment for the T1A tumors where they will come in. Exact Sciences is actually funding the scores in that setting, and if it's less than 18, they can enroll. Other questions that come up are certain histologies. Are they eligible to not have a recurrence score or to have a recurrence score? And we don't have any requirements histologically. It's really based on size of a T1 tumor. So I think this is a study that, that does not mean to minimize the importance of breast radiation. Breast radiation is an important component, and it's really the breast radiation following a lumpectomy that makes a treatment equivalent to having your breast removed. So it's the combination of surgery and the breast radiation that gets you to the same outcome as having the breast removed. So we're not minimizing how important that is. We're just trying to identify which patients maybe can be okay with surgery alone and not lose that good local control. So I don't think it's about adding importance to one modality versus the other. It's about what can we do that's patient-centric, based on biology, to get the right treatment to the right patient.